So holding this mic in the left hand and the remote, almost I flushed all my memory thanks to PowerPoint so that I could remember what to tell. The thing is, first of all, I would like to thank Dr. Mitch Stuckey, who has given me this opportunity to present this presentation. I've been attending this PPG quarterly meeting. I'm one of the hospitalists, by the way. I'm Dr. Ethiraj. And every time I see this pyramid, sorry, not the pyramid, the diamond being presented by Mike Packnett, and I always see the service excellence being low. So we thought we should do something for this. So we started this committee called Physician-Patient Experience Committee around the beginning of this month, this year, 2017, January to February. The reason we started and kept a name for this as a physician-patient experience is, physician is the chief influencer for patient experience. You know, when it comes to communication, physician is a chief influencer. We can say nurse, but nurse is a proxy. The physician is the number one, and we should hold physician as accountable for all the patient experience. That is my theory, and that's why we started this as a physician-patient experience committee. Now, as you can see, this graph, I think pulled by Tom Dennis, is one of our director for patient experience. It shows clearly Parkview is running low on the communication with the doctors, between the doctors, and then the doctor explaining to the patient is running low. And this Parkview, especially the score 43, that's a percentile compared to other pools of hospital within the PRC group. So what we did is, we've been doing this every month, once a month. We take the patient's voice, we discuss, and also we actually get the real patients who talk about their experience, positive and negative. And then we came up with this strategy. Where we lack is physician-physician communication, physician-nursing communication, physician bedside manners, and then the subspecialist collaboration in the rounds, and then the patient education tools needs to be improvised. So essentially, when I'm a junior physician and I try to talk to any senior physician or even my colleagues, they think, you know, am I trying to teach? No. If you look at this graph, this particular slide, you see this adult learning process. There's so much room to learn, and especially when we are in this unconscious incompetence area, if that is our blind spot, we will never know. So somebody has to show that is a blind spot. But how do we know that? You know, if we are poor in one particular type of communication, we will never know, and we will never improve. So that unconscious incompetence has to move all the way to unconscious competence. Because as a physicians, whether medical or surgical, we are very skilled in so many aspects. But when it comes to communication, that could be our blind spot. So basically, we started raising awareness within the hospitalist group, and then we started this subspecialist hospitalist collaborated committee, wherein we advocate on this: pull a chair and sit down and talk to the patient. And then we have this physician chair being marked in our medical floors, in 6th floor and 7th floor, as one of the initiative. And listening without interruption, relate with your eyes, and clear communication. And this is one of the research from Mayo, one of my favorite slides. It shows that the time spent on sitting 1.04 minutes, but perceived as 5 minutes. And the same thing, standing, if you stand and talk to the patient, 1.28 minutes, it's perceived as 3.4. So definitely there is something to do with perception. We can't change that. But there is something connected to sitting and standing. So I just wanted to do an experiment. I just gave my camera to my patient and asked him to take a picture. He said, why you want me to take a picture? I just said, please take a picture. And he said, clearly, the picture on the right is, you're looking good. The left is not, you're ugly. And it's a very simple experiment. We don't need any scientific research or anything. And in fact, one of the inference I got, which is not connected to the patient experience, is if you want to take a picture of your spouse, take the one on the right, not the left. So that's another thing. So it's very simple. We got to sit down and talk. It's very simple manners. When somebody's standing, we got to stand and talk. Well, of course, this is an exception. I have to stand and talk because, you know, we can't see eye-to-eye contact in this stage. But when it comes to patient, definitely. So this one of the adult learning process that we wanted to improve. So we do this communication skills lab among the hospitals. The reason to do this is we act as patient, we act as a relative, we act as a physician there to see how the others feel. and that's driving empathy out of our heart. So, that's basically the soft skills, difficult to teach, difficult to learn. But this is easy, the technical skills. So we wanted to improve communication tools, so we are coming up with this. I think there are a lot of people behind this. Microsoft Teams, I think Amy is one of the key person in this one. This is a app we want to use among the physicians to communicate. I will show you soon. And the Spoke is another app that will be helpful. If we get all the physicians' on-call's name on one page, even the operator doesn't have right now. So we wanted them to have that on one page, and then we can easily communicate either by texting or calling, depending on the priority of the call. And this is one of the, just a quick view, wherein I just say patient's room number and a patient's name. This is HIPAA complaint, so you can put the patient's name and the room number, and then I just take a picture of the EKG and send it to all the people, all the physicians on the case. And accidentally, we see Dr. Peterson here behind me, and he says, I'm not a cardiologist, but that doesn't look good. I agree, it's a ST elevation, so I'm going to call the cardiologist dad. And it was just a test message, probably. I don't know if he knows this picture was there in the slide. So anyway, so essentially this puts everybody on the case to know what's happening with the patient. Being a pulmonologist or being a gastroenterologist doesn't mean you should not know the patient had a STEMI. This is a quick way to communicate among ourselves in that particular given case, in that particular episode. So this is one of the applications I thought. And if you see this back, the questions for my doctors, another pilot we are doing, Tom Dennis is the one behind this pilot. We want to give this book to all the patients at the time of admission in the 6th floor, and we are also piloting in Randalia, so that patients can write down the questions, because as soon as we go inside the patient's room and ask, do you have any questions? They always say no, because they're so afraid to ask a question, and they even forget the question. So even in this stage, after 5 minutes presentation, if I say, do you have any questions? Everybody's going to say no, or you don't even ask me a question. But you will have a lot of questions in mind, so you can email me later. That's different. So in the same way, questions for my doctor notebook is going to be deployed very soon, so that way we'll get more questions from the patients. So our doctor explained score should increase. So that is our theory behind this pilot. So our expectation is very simple. We want the physicians to be engaged and alignment with the PPEC goals. Our goal is same as PARQ goals. Basically, I remember the PARQ vision, excellent care every person every day. So we want to achieve this by physician engagement and disseminating the evidence behind these powerful communication tools. And also transformative leadership. I saw the slide on various physician leaders being in the structure. We all want them to model the way and then inspire your shared vision, and then challenge the process. If somebody's not using chair, challenge them, and then enable others to act, and then enable the heart. So these are the simple 5 principles for transformative leadership, and I think this will really transform something that if you want to achieve. And we want everybody to be involved in this PPEC committee, so that's the reason I'm presenting here today. And I have a quick video. Does it work? I don't know how it does work. Anyway, so this video doesn't work. It's not as effective as if I talk, but is there any way to play this? Or? Okay. So this is Devi Prasad Shetty. He's one of the cardiothoracic surgeon. Essentially, he's been called for a house call. In those days, I think they call house calls. And he says, I'm a cardiothoracic surgeon. Why are you calling for a house call? And then they insisted, no, you have to come for the house call. And then he goes there, and the patient happens to be Mother Teresa. And he is so impressed, and of course anybody will be impressed. What he notices is the power of touch. And essentially in this video, he says that the power of touch is very powerful. When we see the patient, we already know their lab results, we already know the CAT scan, we already know the diagnosis. We don't even have to go inside the room. That's how powerful Epic. But still, the power of our stethoscope, putting the stethoscope and touching the patient on the shoulder, or like a professional touch, will really transform the way they feel. And that's what he says in this video. So I thought the power of touch is another 5th principle we wanted to add. And that's the reason I put this video. So anyhow, if you have any questions, as I said earlier, you can email us, and also you can contact Julia Walker. Thank you.